lucky to welcome on our next clinical Pearl presenter, PGY2 emergency medicine resident. I guess you'd say almost finished PGY2 emergency medicine resident, a future emergency medicine pharmacist in the Orlando area, Tanner Smith. Tanner, welcome, my friend. How are things doing down in probably swampy Florida at this point in the year?
Yes, very hot, very humid. It's a pleasure to be here.
I think that the rest of the country is getting a little taste in this heat wave of what you all probably experience on a regular basis. And I'll tell you what, I'm jealous of you all January, February, not jealous June, July with this weather. It's been tough up here.
For sure. Yeah, it gets hot definitely down here in Florida. But growing up here, definitely getting used to it.
You grew up. All right. So is it like when you're in that weather, is it like a winter skin for cold weather? Do you have like do you just have like a different sort of like hot weather skin essentially?
Some days are worse than others. I feel like I have gotten used to it when I've been running in the hot, but there are definitely some brutal days. So, it depends on the day.
Yeah, yeah, yeah. Well, the real reason we are here, and as a non as a non-tox person, at times N-acetylcysteine dosing can make me feel like I'm reading a Dr. Seuss book, right? One bag, two bag, three bag, four. But I'm excited for Tanner to help clarify some of our different dosing strategies for one of our well-known and most used antidotes in emergency medicine. So the floor is yours.
Thank you for that. So, just a quick background on acetaminophen overdose. So, acetaminophen is one of the most widely used analgesic antipyretic agents. It's incorporated into hundreds of medications, leading to many individuals underestimating its toxicity. Acetaminophen overdose events occur from both intentional as well as unintentional ingestions, and this drives its role as a leading cause of acute liver failure. In fact, acetaminophen is actually implicated in approximately 50% of cases of acute liver failure in the United States, and with early recognition and treatment is crucial. When treatment is initiated within 8 hours of ingestion, mortality is extremely low. However, if treatment is delayed and acute liver failure develops, mortality rates can escalate to about 28%, with nearly 1 in 3 patients requiring liver transplantation. So, looking at the pathophysiology of acetaminophen toxicity, this is primarily a consequence of its metabolic conversion in the liver. So, under normal therapeutic conditions, the majority of acetaminophen is processed via glucuronidation and sulfation. This results in non-toxic metabolites that are readily excreted. However, a small portion of acetaminophen is oxidized by CYP2E1 to form N-acetyl para-benzoquinone, otherwise known as NAPK. Under usual circumstances, NAPK is neutralized by conjugation with glutathione. However, in the event of an overdose, the safe glucuronidation sulfation pathways become saturated. This leads to a higher, much larger fraction of acetaminophen being diverted to the CYP2E1 pathway, leading to excess production of NAPK. Once the glutathione stores are depleted, NAPK accumulates and begins to bind to essential cellular proteins and membranes, and this binding to hepatocellular proteins causes oxidative stress, mitochondrial dysfunction, leading to cell necrosis, liver tissue damage, and in some cases, the kidneys and other organs might also be affected. There are 4 stages of toxicity. So, in the first stage, in the first 24 hours, hepatic injury has typically not occurred yet, and most patients are often asymptomatic, with clinical findings, if present, being nonspecific, including nausea, vomiting, and diaphoresis. Stage 2 is usually occurs 24 to 72 hours after ingestion, and this is represented by the onset of hepatic injury, with AST being the first lab value to rise. ALT will follow along with other markers of liver injury, such as rises in bilirubin, prothrombin and INR. And at this point, the patient may also begin complaining of right upper quadrant pain. At stage 3, 72 to 96 hours after ingestion, this is typically defined as the maximal hepatotoxic time. With peaks in AST and ALT usually occurring at this time point, the patient will continue to experience abnormalities of PT, INR, glucose, lactate, creatinine, and pH, which can be good determinants of prognosis and treatment. At this point, fulminant hepatic failure can develop and persist with encephalopathy, coma, hemorrhage, and lead to death. At stage 4, after 4 days, if the patient survives, they will begin to show signs of hepatic regeneration. Liver function tests will gradually improve, symptoms resolve, and the patient enters a convalescent phase that may last several weeks. At this point, full recovery is possible. However, in cases where the liver damage is too extensive or complications arise, patients may continue deteriorating, and without liver transplant or additional interventions, the outcome can be fatal. So what exactly goes into the decision to treat? So there's two main things that we look at. This is ingestion details. So it's crucial to ask about the amount ingested, the time of ingestion, what products were ingested, for example, acetaminophen alone versus acetaminophen PM, co-ingestants, and whether it was a single acute overdose or repeated supratherapeutic ingestions. For instance, if a patient reports taking more than 10 grams or over 200 milligrams per kilo, treatment is usually warranted. However, we also like to look at timing of the ingestion. So for patients presenting between 4 and 24 hours after ingestion, acetaminophen levels might be plotted on the Rumac-Matthew nomogram, and levels that fall on or above the treatment line indicate a high risk of hepatotoxicity. It should be noted, though, that the nomogram is designed for single acute ingestions, and in cases of chronic or staggered ingestions, its use isn't valid. In these situations, the decision to treat hinges more on the dose history and clinical context, and it's important to note that the efficacy of the antidote is highest when initiated within 8 hours of ingestion. If the patient presents early, treatment may begin immediately, even before labs result, and especially when the timing is uncertain or in order to reduce the risk of liver injury. So, what exactly is the antidote? Well, as we mentioned earlier, the antidote is N-acetylcysteine or NAC. Its mechanism, it has three various mechanisms. First, the N-acetylcysteine augments sulfation, one of the main pathways of normal acetaminophen metabolism. NAC also acts as both a glutathione precursor and substitute to help detoxify NAPK. Lastly, NAC treats toxicity through nonspecific mechanisms that preserve multi-organ function and possibly limit the extent of hepatocyte injury. NAC is available as both an oral formulation and an IV formulation. When given orally, the dose is 140 milligrams per kilo times one dose, followed by 70 milligrams per kilogram given every 4 hours for 17 doses for a total of 72 hours. The IV regimen utilizes a three-bag regimen. The first bag contains 150 milligrams per kilogram and is given over 1 hour. This is followed by a second bag, which contains 50 milligrams per kilogram and given over 4 hours. And this is then followed by a third bag of 100 milligrams per kilogram over 16 hours. But this third bag might be extended in certain situations. And just to throw in a little fun fact, oral N-acetylcysteine was actually used to be administered IV using a filter before an IV formulation was officially approved. When it comes to N-acetylcysteine dosing, I'll be focusing mainly on the IV dosing, as there was one study that showed that IV NAC was administered in almost 94% of cases. So again, I want to emphasize IV NAC is dosed with a three-bag regimen. One bag dosed at 150 milligrams per kilogram given over 1 hour, followed by another bag of 50 milligrams per kilogram given over 4 hours, with a third bag of 100 milligrams per kilogram given over 16 hours, but again can be extended in certain situations. So I wanted to see, what's up with this crazy dosing regimen. Really, it's complicated. The dosing emerged from a blend of preclinical experiments and early clinical trials that include the patient's liver size and glutathione concentrations, which really aim to identify the optimal way to replenish glutathione and prevent liver injury. And Dr. Barry Rumack, the guy from the nomogram, explains that the history and all calculations involved in an article published in 2012 that was titled Acetaminophen and Acetylcysteine Dose and Duration, Past, Present, and Future. So, a three-bag protocol with each dose receiving its own bag is prone to errors. These errors can range from the bags being hung in the wrong order, incorrect rates entered into the pumps, and delays in therapy either due to switching of the bags or availability of the bags from the pharmacy. And in a study from Hayes et al., published in 2008, they found that there was a 33% rate of errors with IV N-acetylcysteine using a three-bag regimen, with 41 out of 84 of these errors being resulting in an interruption in therapy greater than 1 hour. So one way to combat that is to utilize a simpler regimen using two bags. A two-bag method has been adopted by many health systems and poison centers around the United States, and the two-bag regimen for N-acetylcysteine is essentially a streamlined approach that combines parts of the traditional three-bag protocol with the goal to retain the pharmacologic efficacy and replenishing glutathione while reducing the dosing complexity. One method of using two bags is to combine the last two bags of the three-bag regimen. So this gives two bags containing 150 milligrams per kilogram. The first bag is given over 1 hour, and then a new bag is hung, again with 150 milligrams per kilogram. And then you run 50 milligrams per kilo over 4 hours, then change the rate to 100 milligrams per kilogram to run over 16 hours. And while this method forgoes the possibility of nurses mixing up the two bags, it does involve the nurse having to change the rate in the pump, which may cause errors or be delayed in a hectic ED. Another method is to combine the first two bags in the 3-bag protocol into one bag. So now bag one contains 200 milligrams per kilogram, and this bag runs over 4 to 5 hours. Most studies use 4 hours, but currently at UF Jacksonville, we use 5 hours as this keeps the 21-hour dosing schedule to avoid confusion. And then bag two contains 100 milligrams per kilogram of N-Acetylcysteine, and again, this runs over 16 hours. An in-house study from our poison center actually revealed a decrease in the error rate from 39% to 21% when we switched from the first two-bag method to this two-bag method. Several studies have showed that the two-bag protocol is associated with fewer medication errors, and it's linked to a lower rate of non-allergic anaphylactoid reactions when compared to the traditional three-bag regimen. Cole et al. In 2023 published an article titled "Is Two Better Than Three?" And this was a systematic review that evaluated the effectiveness and safety of the two-bag intravenous N-acetylcysteine regimens for acetaminophen poisoning compared to the three-bag protocol. 12 articles met the final inclusion criteria, 10 of which included two-bag N-acetylcysteine regimens, with 9 articles evaluating the two-bag 20-hour regimen that was just mentioned. So again, 200 milligrams per kilo given over 4 hours and 100 milligrams per kilo given over 16 hours. They assessed each study in terms of rates of hepatotoxicity, incidence of non-allergic anaphylactoid reactions, along with other adverse effects, medication errors, delays, and interruptions in therapy. Across multiple studies, the two-bag regimen demonstrated similar effectiveness in preventing hepatotoxicity compared to the three-bag method. The two-bag method was also associated with fewer non-allergic anaphylactoid reactions, with 8 out of 9 studies showing a statistically lower rate and less patients needing intervention on these reactions. There were also significantly fewer medication errors and interruptions among the studies in patients receiving the two-bag regimen, and the authors of this article concluded that the two-bag N-acetylcysteine regimen offers an appealing alternative to the three-bag method, and it maintains comparable efficacy in preventing acetaminophen-induced liver injury while reducing both adverse reactions and operational complexity. So this leads me to my few clinical pearls for the two-bag dosing regimen and different NAC dosing schemes. So first is that in 2023, a consensus statement on the management of acetaminophen poisoning in the US and Canada was published. In this article, the authors recommended the use of an FDA-approved or published regimen that delivers at least 300 milligrams per kilogram of N-acetylcysteine, either orally or intravenously, during the first 20 to 24 hours of treatment. And this article specifically states that there is no one dosing scheme to use, but that there are more than 15 reported strategies. And again, as long as one of these strategies that you choose gets 300 milligrams per kilogram N-acetylcysteine to the patient within the first 20 to 24 hours, then it's effective. The next is to reassess your patient. So a common clinical error is to administer N-acetylcysteine for a period of 20 to 21 hours and then discontinue without reassessing the patient. So as I mentioned earlier, some patients require prolonged infusions in the setting of ongoing hepatotoxicity, persistently detectable acetaminophen levels, and continued coagulopathies. In this case, usually the 16-hour bag is continued at the same rate if the patient requires the extended infusion. And I wanted to emphasize that it's important to consult toxicology to determine the duration of this infusion. So again, it's important to call the Poison Center at 1-800-222-1222 in order to tailor the N-acetylcysteine regimen to the specific patient. They will help you determine when to initiate, continue, increase the dose of, or stop N-acetylcysteine, and frequency of LFT monitoring, INR, and acetaminophen level monitoring. So moving on to some operational pearls. So one of the things that might make this easier is using stat versus non-stat bags. So by making the first bag stat in your order set alerts the central pharmacy team that the medication is needed urgently. And once the first bag is made and delivered to the bedside, this gives the central pharmacy team another 4 hours at least to ensure that the second bag is made. Additionally, sending one bag at a time ensures that the doses don't get mixed up. Next is, whether to concentrate or to double the rate when trying to achieve a double dose. So in certain scenarios, the Poison Center may recommend double dose NAC. These include patients with extremely high acetaminophen levels, massive overdoses, if the patient's receiving drug removal via CRT or HD, or if the patient develops fulminant hepatic failure. So double dose could be achieved by you doubling either the N-acetylcysteine concentration in the bag or doubling the rate of the infusion. Typically, I prefer to double the concentration, as this decreases the amount of fluid the patient will be receiving over time. And again, it's really important to consult a toxicologist to determine the need for double dose N-acetylcysteine. My last operational pearl is to develop a dosing strategy that fits your specific institution operationally. Again, with the goal being to deliver the 300 milligrams per kilogram of N-acetylcysteine within the first 20 to 24 hours while minimizing errors. What works for one hospital may not specifically work for every hospital. So, what are my thoughts on the two-bag regimen? So, I think utilizing a two-bag regimen of N-acetylcysteine, using a 200 milligram per kilogram bag given over 5 hours, followed by 100 milligrams per kilo given over 16 hours, is the ideal regimen. There seems to be a low risk of mixing up the two doses, for one, considering both bags are typically uh, produced in different sizes. In addition, the central pharmacy team making the 5-hour bag first, entered as a stat, the nurse should only really be handling one bag at a time. Furthermore, there's less interruptions as there's no need to change the rate in the pump, and this typically only requires one bag change, and there's less hassle for an already busy ED staff. There's less delays as the pharmacy can again make the first bag stat, and then they have 4 to 5 hours to make the second bag. So all that to say, really when it comes to patients with acetaminophen overdose, again, calling the Poison Center at 1-800-222-1222 is imperative to the patients, as again, they can help determine the specifics of N-acetylcysteine dosing, as well as monitoring of LFTs, INRs, and acetaminophen levels.
What a great review. Talk about trying to clear up a muddy water of all these different bags and doses. And for those who aren't in a busy emergency department, they may be listening and being like, what do you mean they have to change the pump once or twice? But like, I've worked in these busy emergency departments, and it is all hands on deck. You get the sickest of the sick. And again, these people aren't coming in typically at 9 a.m., right? This is like
Yeah.
a 2 a.m. sort of. It's never when you have all of the resources.
Mhm.
Love that you highlighted the Poison Center number. Also want to put a plug. One of the old episodes, shout out Jimmy Leonard, who's now in the Washington Poison Center, Washington State. Did an episode into acetaminophen toxicity and some of these different dosing regimens. So if you enjoyed this, can't recommend that enough. And I love that you highlighted the um, uh, article from the Dr. Rumack kind of talking about how they developed the dose. It is wild how they calculate like glutathione concentrations and liver size. It is like, if you want to feel like, I read that and I was like, I feel dumb like looking at this. Like, it's a different language, but it's way more hands-on than we're used to. So that was fascinating when you kind of see where it actually came from. You'd argue maybe some of the best evidence in the tox world, right?
Yeah, for sure.
But Tanner, this was awesome. Appreciate you coming on. Congrats again about the new position. Appreciate you sharing some of your knowledge, but also tips and tricks, because this is not only a clinical side, but there are big operational pearls. And I thought you did an excellent job of highlighting those. So appreciate you, my friend.
Awesome. It was great to be on. I appreciate the invite.